Well, good morning, afternoon, or evening, everyone. My name is Lorraine Racusen. I'm the moderator for this webinar, which will feature Dr. Kim Solez. I wanted to remind the audience that questions and comments can be asked and typed in throughout the presentation, and at the end, Dr. Solez will reply to those comments or questions. I will read them for the audio record. Now, I just wanted to briefly introduce Dr. Solez. He received his MD from the University of Rochester with honors and distinction in research and entered a residency in pathology at Johns Hopkins, where he continued to focus on research under the mentorship of Dr. Robert Heptinstall. He served as chief resident, joined the faculty, and was promoted to associate professor of pathology and medicine. He developed an early interest in transplant pathology, and that has remained a major focus of his career. In 1987, he was recruited to the University of Alberta as professor and chairman of the Department of Pathology, where he currently is professor and director of experimental pathology. He has been an NIH and Alberta Heritage Foundation funded researcher and was an early adopter of the use of the internet in medicine. Under the auspices of the NKF, he established and maintains the Nephrol online discussion group, as well as many other websites in the general field of medicine. He received the Distinguished International Medal from the NKF in 2009. He also served as organizer and chair of the ISN Commission on Acute Renal Failure and served on the ISN Council. In the early 1990s, recognizing a need for standardization of kidney allograft rejection diagnosis, he organized the first Banff Conference on renal allograft pathology, which led to publication of the first Banff Working Classification. Subsequently, he has organized Banff meetings every 2 years since, resulting in important refinements and updates to that classification, but also now dealing with other solid organ allografts and many aspects of transplant pathology. He is chair of the board of the Banff Foundation, which continues to support this meeting and related activities. An important aspect of his work has been teaching and mentoring. In addition to the online discussions groups, he has over 175 articles and many book chapters and books edited. He has fostered the careers of many young pathologists throughout the world. And his new focus, as we'll hear, is on the technology and future of medicine and the role pathology will play. So without further ado, Dr. Solez.
Well, thank you very much, Lorraine, for those kind words. So today I'm going to take you through renal transplant pathology, the rest of the story beyond rejection, and future perspectives. I should say at the beginning that I have no conflicts to acknowledge. And as many of you would be aware, Michael Mengel gave a webinar like this on October 20th, concentrating mainly on rejection. So in this talk, I'll talk about the remaining issues in transplant pathology, general approaches, and the future, especially the future. Now, I always think that rooms and places are important in the generation of ideas and actions. This is a room very familiar to both the moderator, Lorraine Racusen, and me. It's the library on the 4th floor, Johns Hopkins Hospital. I wrote a lot of my early papers there, and it's where I was when I learned that the chairmanship at the University of Alberta was open. And so it's where the conversation occurred that kind of led to my coming here to Edmonton. And other places, Paris and Brussels, have been very much in the news recently. I did significant portions of my training, especially in immunofluorescence with Liliane Stryker at the Tenon Hospital in Paris, France. And the Acute Renal Failure Commission Disaster Relief Task Force meetings in the 80s and 90s, many of those meetings were held in Brussels at the Metropole Hotel in the Marie Curie room, which you see there. And right now, I'm coming to you from the cybernephrology office at University Hospital at the University of Alberta. And this is quite a unique place. I've shared this room as my office since last May 15th with students and fellows, and it works very well. In the early morning, I'm the only one here, and then a little bit later the fellows come, and then later on the students roll in, and it's a very happy place. So that's where this webinar is coming to you. What are we planning to do? What are the objectives of this presentation? Well, it'd be pretty boring if it was all a view backwards. So you get 100 years back and 30 years forward. And I think it may be the first time anyone's ever done that kind of look with you. So 130 years history of transplant pathology, and a general approach to transplant pathology special stains adjunctive procedures to introduce you to the concept of tissue engineering pathology and show its evolution from and relation to transplant pathology, and to present transplant pathology and tissue engineering pathology in an accessible way. The TTS has a very heterogeneous membership, and I hope that most members who might view this presentation would be able to understand it. And presenting in an accessible way so people who do not regularly think about anatomical pathology, like aviator Charles Lindberg, could understand it. To introduce you to prototypical people from the future your offspring may resemble someday, like in 2045. Now, when you're looking at this slide, you're wondering, why did I mention Charles Lindberg? Well, Charles Lindberg was possibly the most famous person in the early half of the first half of the 20th century, because he did a solo flight across the Atlantic in 1927. And after that, he could have done anything that he wanted. But what he chose to do, believe it or not, even though he had no science background, was to join Alexis Carrel in doing transplantation research, basically, the development of perfusion and bioreactor technologies. And so there's an award in his honor, the Alexis Carrel Charles Lindberg Award at the Medical University of South Carolina, Charleston. Many famous people have received that award. And there's a statue associated with it that is named Elizabeth, after Elizabeth Morrow, who died as a result of heart disease. And it was Charles Lindbergh's interest in her medical condition that led him to do this. So it's good to make our topics accessible. What had he done before he crossed the Atlantic? He was an airmail pilot. Now, Alexis Carrel won the Nobel Prize, of course. He started the modern field of transplantation in 1902 by describing surgical vascular anastomoses for transplantation, work that eventually led to his receiving the Nobel Prize. And the first transplant pathology paper was published then 13 years later in 1915. And it is by Hesselberg, Comparison of Autoplastic and Homeoplastic Transplantation, Thyroid Tissue in the Guinea Pig in JX Med. And so this year, 2015, is the centennial of that first publication in transplantation pathology. Now, as Dr. Racusen has said, my mentor was Robert Heptinstall, but it's a bit ironic. Robert Heptinstall was not terribly interested in transplant pathology. His main love was in native kidney pathology. And so very early on, I was exposed to the person who wrote the chapters on transplant pathology in the early editions of Dr. Heptinstall's book, and that is Kendrick Porter. And Kendrick Porter collaborated for more than 30 years with transplant pioneer Thomas Starzl. So that gives a real University of Pittsburgh kind of flavor to at least my early education in transplant pathology. And then, as Lorraine said, 24 and a half years ago, she and I directed the first Banff meeting, which created the Banff Classification of Transplant Pathology. And it began in the kidney, was then extended to liver, pancreas, heart, lung, and composite tissue graft, pancreas. Meetings also considered heart, lungs, small bowel. So it uses semi-quantitative scoring, 0 to 3 plus in diagnostic categories. It's a pathologic classification of all pathologic changes, not just rejection, everything that can occur in a transplanted kidney. And it includes such things as peritubular capillaritis, polys and peritubular capillaries, and antibody-mediated rejection, the characteristic peritubular capillary staining for C4D in antibody-mediated rejection, and the multi-layering of peritubular capillaries that you see in chronic antibody injury. And there has, for over a decade now, been a kind of healthy tension between the very old-fashioned techniques of light microscopy and the idea of using gene chip technology. But the thing is that whatever technologies one is using needs to be capable of looking at all the various conditions that may actually afflict a transplant kidney. And at the present time, most biopsies show something other than rejection. So they have to be capable of showing all the various disease processes other than rejection that may afflict the transplanted kidney. And in theory, gene chip technology would be perfectly capable of doing all that, but it just is not able to do that at the moment. So then there are diseases which very commonly recur following transplantations. So these are very familiar diseases to all renal pathologists, which tend to recur. And of course, EM, electron microscopy, is a standard modality used in kidney transplantation. One of the most common diseases which uniformly recurs is dense deposit disease, and that entity can only be detected using EM. Then there are diseases which commonly occur de novo following transplantation. This includes diabetic nephropathy, anti-GBM nephritis in Alport syndrome, a very specific situation due to the lack of certain antigens in patients with the Alport syndrome that are then present in the transplant. IgA nephropathy, membranous nephropathy, FSGS, and post-infectious GN. So post-infectious GN we usually think of as occurring in the native kidney, but it very commonly occurs de novo also in the transplanted kidney, and has this characteristic aggregation of polymorphs in glomerular capillary loops. So a transplanted kidney is still a kidney. It's a denervated kidney. It doesn't have quite the same lymphatic supply. It is under threat of being attacked by the host, but nevertheless, in other respects, it's still a kidney. So it needs transplant biopsies, transplant kidney biopsies need to be examined with the same degree of care as native kidney biopsies. The report must always mention the number of glomeruli and vessels and comment specifically on the 4 histologic compartments, the tubules, the interstitium, glomeruli, and vessels, and light microscopy, electron microscopy, and immunofluorescence or sometimes immunoperoxidase are standard modalities applied. Now, this simply shows the four histologic components of the kidney. You have the interstitium, the tubules, the glomeruli. This is the JG apparatus here where renin is made, and the vessels. So all of those components should be commented on in any report on a transplant kidney biopsy. And you need to do special stains. Here to the far left, this loop that you can see right there has silver positive spikes coming from it, and that's characteristic then of membranous glomerulopathy. So you need to always do those special stains. There needs to be expertise in doing and interpreting special stains, which should include either Marsh's scarlet or PTAH for fibrin. So, for instance, in anti-GBM disease, you commonly get crescentic GN. And here we're looking at a crescent here, this group of cells surrounding the compressed tuft in the center. So that would be characteristic of crescentic GN. And in anti-GBM disease, this is characteristic linear GBM staining. And in any case where you have active proliferative changes and crescents in the kidney, you expect to see red cell casts in the urine, and you can also see red cell casts forming in the kidney in a kidney biopsy, as you see here. And then there are diseases which have special features no other disease has. In lupus, which can recur in the transplanted kidney, you get granular peritubular staining as well as glomerular staining, and you get fingerprint-like structure in the electron microscopy. These structures seen here. Now, this slide should say BK virus nephropathy. So this is an entity that actually does not very commonly occur in the native kidney, that is specific, a specific infection that often afflicts and is an important disease entity in the transplanted kidney. And similarly, C4D staining is of specific interest in the transplanted kidney. Okay, so up until now, I have talked to you pretty much about conventional transplant pathology. And now I'm going to shift a little bit, and you may wonder how important what I'm going to talk about for the rest of the time is, how relevant to your life it is. And I thought I would just paste something from yesterday's JSON. Let's see how this works. So that reference there is an editorial which talks about the ever-expanding kidney repair shop. Just came out yesterday and is directly related to what I'm going to talk about now, which is tissue engineering pathology, because eventually the transplant pathologists of today will become tissue engineering pathologists of tomorrow, and the field of transplant pathology, once we're doing tissue engineering transplantation, will expand at least tenfold. So it's an exciting future. Now, who influenced this presentation? You can see the names there of the people that I'm writing an article with about this, but I also teach a course on technology and the future of medicine, a unique course talking about, let's say, 30 years in the future. And there are 3 well-known regenerative medicine experts who teach in that course by Skype: Jason Wertheim, Harold Ott, and Shuvor Roy, and they have also influenced this presentation. Shuvor Roy, I think right now, is a very happy researcher because they have just received a $6 million grant for the bioartificial kidney. So there again, if you're reluctant, thinking that this will never happen, I assure you that that $6 million grant will actually have the effect of moving this field forward quite quickly. Now, what about the terms here? You've probably heard 3 different terms: regenerative medicine, tissue engineering, cell therapy. They all talk about the same thing, but there are various fads, as you can see from these Google trends, that tissue engineering was originally the most popular of the 3 terms. Then cell therapy has been increasing and is now the most popular term. And regenerative medicine has stayed pretty much steady. Cell therapy is just not specific enough, I think, for most uses. But I wanted you to know that all 3 can be used in the same way. And this is maybe the most important slide in the whole presentation in terms of policy. And that is because transplantation reaches fewer than 10% of those who are in need. And that leads to the very riveting fact that presumably once we enter the phase of regenerative medicine pathology, we are going to be in a situation where we can provide organs for everyone who needs them. And so worldwide, 1.2 million people per year are in need of transplantation for end-stage organ failure. Current transplant protocols reach fewer than 10% of this number. So regenerative medicine can save the remaining 90%, over 1 million people annually. And you can also imagine that the field of transplantation will expand very much. Lest you think this is all about the future, regenerative medicine is already here. We're already able to use it to generate tubular organs, simple tubular organs such as the trachea, for instance, the bladder. And lest you think that I'm talking about something that nobody at the University of Alberta up here in the frozen north knows about, we are actually the center or one of the main sites for the ViaCyte trial, which uses encapsulated pancreatic progenitor cells as a regenerative medicine implant in patients with type 1 diabetes. And as many of you will know, that trial is already underway and looks quite promising at the moment. There are other sides of stem cell biology that are less positive, and so rather than giving you the idea that stem cells are wonderful and everything about them is wonderful and we can be totally positive about this, the fact is that stem cells are also subject to a great deal of hype, of over-promising. There is a substantial problem in the world of stem cell tourism, estimated to be a $3 billion a year industry and growing. And there is also a substantial amount of documented intellectual dishonesty going on in the area of stem cell research. So there are many things that one might regret. And once again, at least in terms of stem cell hype and stem cell tourism, Edmonton and the University of Alberta has here Timothy Caulfield, who is perhaps the person at the Health Law Institute here who is doing the finest work documenting stem cell hype and the extent of stem cell tourism. So what do we do about that? I think we can channel the energy of the regret we felt about stem cell hype, stem cell tourism, and stem cell fraud into support for the enormous benefit for humanity that can come from well-conducted stem cell research. And it really goes back in a way to my high school graduation speech, Youth Rebellion, many years ago, when I talked about sublimation, rechanneling the raw energy of primitive instincts into productive pursuits. Same concept applies here, channeling the emotional energy we feel about stem cells into support for high quality stem cell research. And that will then have many positive outcomes. The positive aspects: stem cell therapies, the true hope, has potential to reverse three looming problems in medicine. And you will probably all be aware of these three problems to some extent. One is the loss of luster in transplantation. This is well documented, the best and the brightest. Young people are no longer going into the field, and faculty recruitment has become more difficult. In every way you can think about it, transplantation does not have the luster it once had. And in kidney medicine, there are rather serious workforce problems due to lack of appeal to young people and potential trainees worldwide. It used to be just North American wide, but now it's worldwide. And then this third problem, it is not something that you probably worry about much, but will certainly happen. And that is machines taking over your job because they're smarter than you are and able to do it better. So technological unemployment in medicine due to replacement of human workers by machines, this is also a reality. And so the title of this slide is a little bit humorous in intent. When I say nephrologists and renal pathologists may be the only people still employed in 2045, but this curve that you see on this slide describes Moore's law, the price performance of computing, which is increasing in an exponential way, and it then predicts that in 2029, machines will be as smart as individual human beings, and in 2045, machines will be as smart as the entire aggregate human race. And presumably at that point, machines will be in charge of the future agenda of the world, and we can only influence that or know what's going on or be part of what's going on if we cooperate or merge with them in some way. And what I'm arguing is that the challenge of tissue engineering, pathology, tissue engineering, replacement of organs, sufficiently complex, will probably still need human beings in that area. And that's the reason why I think that nephrologists and renal pathologists may be the only people still employed in 2045. So Sina Marzugi is a student working with me who found an image of what people will look like in 2045. I thought you might find that interesting, and you'll probably remember this image. This is based on trends in the human species and what we think will occur in terms of intermarriage and racial coming together. So this is what human beings are thought to look like in 2045. Now we anticipate in tissue engineering replacement of organs that there will need to be pathologists at pathology, and that there'll be a Banff classification of tissue engineering pathology similar to the Banff classification of kidney transplant pathology and the other classifications that we have for other organs at the moment. That Kidney transplant pathology classification has had significant impact. You might think that something that is now 24 and a half years old would be sort of trailing off in terms of its influence. But you can see that the number of papers related to the Banff classification continues to go up. Particularly this year, there are more than there have ever been. And the most cited papers in AJT, the best journal in transplantation, are those that are the meeting reports or relate to the Banff classification. So you can imagine that with tissue engineering pathology added soon, that this number of Banff-related transplant articles per year will continue to go up. The world is changing rapidly. For a lot of you, your thoughts about the future changed very much when you received this issue of AJT in November 2014 with this article by Doris Taylor about building new hearts on the cover. You may have thought beforehand that regenerative medicine was something in the future, didn't really apply to you, was going to occur later on after you're no longer working, but this suggested that it's actually going on right now and is something active in transplantation, active enough that it should appear on the cover. This certainly won't be the last such cover. And so the world is changing rapidly. We need to begin to think of transplanting cells that go into scaffolds that are treated with bioactive factors that become a tissue engineering construct and ultimately a whole organ, and the various ways to do that successfully and all the things that can go wrong. And it's natural to feel resistance to new ideas, but the idea of jump starting is, I think, appropriate. We need to push against this idea of sort of rejecting stem cell replacement of organs as our future. It is really our future. And so we then need to be thinking about a lot of things: attachment, proliferation, migration, differentiation, remodeling of cells, vascularization. So I'm in Canada. Does the Canadian public want this? Yes, that's also interesting, that if you look at the data on the public opinion polls, the general population is very positively inclined toward regenerative medicine. So I talked about the singularity before, where it's a point at which machines are smarter than the whole human race. But you can imagine singularity in transplantation, which is the moment at which we are regularly using stem cell biology to provide organs for everybody who requires them. There would no longer be a shortage. And down at the bottom part of this slide, you see the standard way of doing that using decellularized scaffolds, where you take an organ, flush detergent through it so that all the original cells are flushed out, and then you put in stem cells which repopulate the organ. And once again, just to remind you, time when we're routinely doing that and providing organs for everybody, this is what human beings are predicted to look like according to National Geographic. So what can go wrong? Well, in Harold Ott's group, this is the paper of Song et al. of a kidney created by injecting neonatal cells into a scaffold. And so one thing is, you would expect that podocytes would stay associated with the glomerulus. So they should be here. And instead, you've got all these podocin positive cells in the interstitium, wandering around. I don't think they would do any harm there, but we don't really know. And a lot of other abnormalities are also present. And there are many problems potentially with the stem cell generated organs, but these are problems that you could help us solve. They're problems of old-fashioned biology, physiology, medicine. And so don't count yourself out. Don't just say that you're going to sit back for the next 20, 30 years and then see what happens. There's a role for you in this. And so we need to get these conversations happening. The recellularized organs clot like crazy. It seems to be impossible or difficult to regenerate more than 80% of the endothelial surface, and the remaining surface tends to clot. It's hard to get the right types of cells in the right places. Podocytes and other cells seem to be terminally differentiated cells. Kidney progenitor cells have been hard to identify, although that JSON article that I referred to at the beginning of the webinar certainly indicates we are making progress there. It's easy to make stem cell generated kidneys that lack the loops of Henle or lack long loops. Could that produce lethal polyuria, or is that something we can get beyond? Many old-fashioned questions of physiology about how stem cell generated organs will work, not just true for kidney, true for every organ. This logo of the Banff Foundation does look like it will still be appropriate for the future. You can sort of fit it in with what the world will look like. So we must morph the Banff Foundation for Allograft Pathology. The Banff meetings must adapt to future changes. And indeed, we're planning in 2017, 2019, 2021 to incorporate tissue engineering pathology into those meetings in an increasing way. So transplant pathologists will become tissue engineering pathologists, pathologists who analyze organs grown from stem cells. It's not something beyond us. It's not something for someone else. We can adapt to a work life that includes this. Someone needs to cross the disciplines, and it can include all of you listening to this presentation right now today. And it's okay to allow the natural resistance to change and nostalgia from the past to motivate you, because many of the questions that need to be posed about stem cell generated organs are old-fashioned questions, like the intact nephron hypothesis, cell regeneration, stunned myocardium, contraction band necrosis. These are old things, and use your nostalgia. Take what you learned in your training in medical school, apply it now to the new questions and challenges of stem cell created organs. Stimulate conversations between stem cell researchers, transplant physicians. And where are we with this? It doesn't have any adverse effect if you consider that we're at the very beginning. There's a lot of evidence for that. A lot of famous people have held that opinion. Richard Feynman, one of the, perhaps the most famous physicists who ever lived, said we're at the beginning of time for the human race, so on. So if we're at that kind of beginning, how could we conceptualize it? Well, one way I like to conceptualize it is by thinking about 1851 and the Grand Exhibition of Technology in 1851, London's Crystal Palace, which you know was the largest glass-walled building at that time. It burned down and is going to be recreated. I think it will be recreated again by 2017. But at that meeting, the Grand Exhibition of Technology, amongst all the various other things that were presented, was the International Classification of Diseases. And if you had to characterize one theme running through the International Classification of Diseases, it was death, causes of death, ways of death, means of death, everything about death, 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 death. And I think that our classification focus is going to be the opposite of that. Focus on sustaining life. Native and transplanted organ diseases can also occur in tissue engineered organs. This includes ex vivo repair. The classification focus of the new pathology discipline of regenerative medicine, tissue engineering pathology, is exactly the opposite of the traditional classification of disease, which starts with causes of death. In regenerative medicine, tissue engineering pathology, the emphasis is on, can this organ sustain life? The degree of normality necessary to sustain life. You can imagine that would include things like normal, abnormalities of unknown functional significance, abnormalities which will impair the main functions of the organ, abnormalities leading to severe organ dysfunction, where function may not be great enough to sustain life. And so the work up till now in the tissue engineering generated kidney, for instance, raises some interesting questions such as, can you really call this a kidney? So this again is from the very interesting study of Song et al. From Harold Ott's group. And you see, that's unlike a renal tubule you've ever seen before. It has interconnecting multiple lumina of all different sizes. The interstitium looks completely empty. So in here there should be cells and there aren't. This glomerulus has way too few cells. And this tubule looks like it's trying to do 100 different things all at once. And so, can you really call this a kidney? And I would say, yes, you can call it a kidney. I mean, it's got tubules, glomeruli, it's got all the usual parts that a kidney has. So, I think it's still a kidney. I don't think our attitude should be to say that it's not a kidney. Our attitude should be to use the new principles of tissue engineering pathology to decide how much abnormality can we accept, what will still work, what should we be aiming for in terms of what the organ should look like. Would anatomical pathology parameters be the only thing used? I don't think so. I think soluble biomarkers might be used quite a lot, and it probably will end up being co-equal or maybe more important than standard anatomical pathology. So the focus, you can imagine the specific questions become, are too many cells missing? Are too many cells in the wrong places? Are too many structures missing? Is there too much endothelial disruption for the organ to be properly perfused? What are the risks of neoplastic transformation? Classification categories should not be one-off, but reproducible, generalizable. So if something only occurs once, then it obviously is not classifiable. But we think things would be reproducible. Tissue engineering pathology has existed since 1967, but it's been dull as dishwater until recently. Most reports were of scaffolds with no inflammatory reaction. So it's kind of like those cop shows and TV where they say, move along, nothing to see here. So tissue engineering pathology in the past has been moving along, nothing to see here pathology. But from today becomes more exciting with novel morphologic changes, lives hanging in the balance, clinical trials starting. I think the trial of the bioengineered kidney will start by 2017, and it will be an increasing focus of our transplant pathology meetings. The meeting in 2017 in Spain, the Banff meeting in Spain, and the Banff meeting in Turkey in 2019, both of those will have major emphasis and focus on tissue engineering pathology. So, believe it or not, this is the next to the last slide. So in our original location, we had mule deer poking their heads into the meeting rooms. Come a long way since 1991. Please, every one of you listening to this, help us transition to the future. This is not something that is a thing apart from your work life. This is something that you could help us with. You know things that can uniquely help this to move this field ahead, and I would like you to help us. And finally, the last slide, we're grateful to the Roche Organ Transplant Research Foundation for funding the establishment, the Banff Foundation for Allograft Pathology from 2013 to 2016 and providing us with our infrastructure. This has many advantages, and we're now thinking about having a permanent endowment to keep the organization going, but this initial 3 years of support was really crucial to that, and so we're very grateful to ROTRF for that support. So, ladies and gentlemen, that is the end of my presentation, and I would be happy to entertain any questions you may have. Thanks very much.
Well, thank you, Kim. As moderator, I want to thank you for that very visionary presentation. We do have a few questions, I think, relating perhaps more to the first part of your presentation, which is grounded in the present rather than the future. And Dr. Randhawa asks, please refresh our memory about the data and observations used to set rejection diagnosis thresholds in Banff 1991. And while ostensibly that deals with rejection, I think perhaps this is an opportunity to discuss some of the differential diagnoses and how the thresholds were set to be sure this is rejection and not some other inflammatory process.
Yes. No, that's a really excellent question. In a sense, it's not hard to find the answer to this question because we wrote about the protocol biopsy studies in every major description of the Banff Classification. So the Banff Classification revisited the article on, the history a few years before that. Both of those articles give all the details of the protocol biopsy studies that go back to 1983. So January 1983, Jim Burdick biopsied the first patient. And you will remember that originally my interest was in acute tubular injury. So I was particularly interested in how much you could get in sort of rejection-like pathologic changes, infiltrates and changes in vessels and tubules in the non-rejecting kidney that just had tubular injury. So there were actually a number of protocol biopsy studies then. There was Jim Burdick's study that began in '83. There was Steen Olsen's study that began around the same time and involved biopsies at 1 and 4 weeks in every single patient at the University of Aarhus in Aarhus, Denmark. And there was also substantial influence from the groups in Paris and also from your own institution, Johns Hopkins. And so we had workshops where we got together and looked at the cases that were particularly interesting. Like we had several where it was clear clinically that the patient was not rejecting, and yet there were lymphocytes sitting on the endothelial surface. They were not under the endothelium, but they were sitting on the endothelial surface and of arteries. So that allowed us to determine that just being attracted to the endothelial surface cannot become one of the criteria for rejection, because that obviously happens in cases that are clinically not rejection. And then the whole decision then of how much inflammatory change we could have in pure tubular injury, and therefore at what point we would say that it became suspicious for rejection was based not only really on the transplant biopsy studies, but really my own interest in native kidney ATN going back to basically 1975, where I made my first trip to Paris and started studying native kidney ATN and wrote highly cited paper on that in 1979. So that was really the background, and these were not numbers pulled out of the air at all. And then I would say, and for people who feel that they weren't part of this, if you think back, I think you probably were. So we did workshops around the world, including workshops in Basel, in Michael Mihach's shop there, and the cases in these workshops were set to include all those specimens that had been used to determine where should the thresholds be, and what is the reason that we can't say that any inflammatory change in tubules is suspicious for rejection? What is the reason that we can't say any lymphocyte, even in the arterial lumen, means rejection? And then there were also, of course, early studies on response to therapy and clinical validation. You can just search on that on PubMed, clinical validation of the Banff Classification, and you'll find many studies on rejection reversal and so on. Now, there was something really amusing that happened. Many of you know about this, but my first ever presentation of the Banff Classification at a meeting, Agnes Fogo and Cynthia Nast kind of heckled me, and I probably deserved it, because I was talking about non-specific tubulitis in scarred areas, and counting that just the same as in non-atrophic tubules. And they rather loudly pointed out how absolutely ridiculous that was it was completely non-specific change having nothing to do with rejection. So now the world is sort of circular, and people talking about total I-score and so on have to think back to original Cynthia Nast, Agnes Fogo, Kim Solez, heckling at the meeting, and realize that, yeah, there are arguments on both sides, but we changed the classification so that you could only count tubulitis in non-atrophic tubules. But that happened after the meeting, at which I got this serious heckling. So, Parmjeet, I hope that's sufficient history of where the thresholds came from. But thank you for the question.
Parmjeet comments in response, I think thresholds based on protocol biopsies need to be revisited now that subclinical TCMR, subclinical ABMR are being recognized. Do you have suggestions how the Banff community should go about doing so? It is a difficult problem since repeat biopsies are seldom done to gauge the efficacy of therapy administered on empirical grounds.
Yeah, well, I guess it depends upon your thoughts about purity and conservative versus radical approaches and so on. I mean, ideally, all the protocol biopsies should be new protocol biopsies, right? And this would be dangerous for patients, maybe. But if you say we're not going to revisit any of the old biopsies, but on the other hand, with nanostring technology, you and other things, you could actually get a lot of interesting data from previous protocol biopsies. You could characterize those cases much better than they have been characterized up until now. And so I think probably it should be a combination of the two.
I think his comment does reflect the fact that once you have pathologic criteria, you can do things like recognize subclinical manifestations of these processes. Dr. Randhawa is responding, but while he is responding, I had a question. You had emphasized the importance of doing IF and EM on allograft biopsies, and of course we all recognize that, but these are expensive procedures. Do you have any specific recommendations as to when tissue should be taken and when these studies should be done? For example, in the context of early dysfunction, say a week after transplant, do you wait until 3 months, 6 months, a year? Do you have different criteria depending on whether the patient is, for example, at risk for recurrence, etc.?
Yeah, well, those are very good questions. I think one of the interesting questions is, can you biopsy too much? Can you biopsy too early? Can you put the patient at risk? I think if you treat and then immediately look for response to therapy, you'll often see some residual inflammatory change, even though the treatment is going to prove to be completely successful. And I think this came from the original MMF studies, in the 90s and so on. So I guess in terms of modalities of what you should do in terms of doing IF and EM, storing tissues or fixing tissues for those costs basically nothing. So in a lot of instances where you're not sure that you need the information clinically, you can still store the tissue in case that initial thought that you don't need IF or EM is wrong and you want to go back to do it. So that's kind of our approach here. And then the question of how much can you do with light microscopy alone? I think nobody's doing EM anywhere in France. France is a developed country, so there are many other places like that are at least not doing EM locally and still practicing high quality transplant medicine. And so it is possible to do that. What it means is you get much better at interpretation of the trichrome stain. Your ability to read the presence of deposits in light microscopy improves, not only because your quality control on the stain, you become very interested in having the stain perfect, but also your ability to see deposits improves when you don't have EM. And And then IF, I guess it depends upon the local belief about recurrence, how early diseases can recur. We do IF routinely, full IF on every biopsy after 3 months post-transplant, but we have frozen tissue that we can do IF from in every single transplant biopsy. So I don't think there are any absolutely perfect answers there. It depends to a certain extent on what the resources are locally. And I mean, we always intended that the Banff Classification should be possible to apply worldwide, including in resource-limited settings. And I still would like to believe that. And as we get into more and more things that specifically require immunopathology and EM, it does mean that in the resource-limited countries, it's going to be hard to follow our protocols. So I don't think there's any perfect answer to that. Let me now see.
There is another question from Dr. Borkar. One of the post-transplant complications in renal transplant is BKV nephropathy. What advancement in treatment or prevention of BKV nephropathy has been made to date? And do you think that bioengineering organ kidney transplants will have less chance of BKVN?
Well, as you know, the science of looking for BK in plasma and urine is getting better and better. And I'm really not an expert on those clinical questions. But yes, I think that the tissue and engineering generated organ, we presume we will not need to use immunosuppression, and therefore problems like BK that are brought about by the immunosuppressed state of the patient will not be a problem in the era of regenerative medicine transplantation. That's a cop-out from the harder parts of your question, but I think that one can readily see a lot of clinical experts in BK, and I'm not one of them. Okay.
I do think that surveillance is improved, and certainly I think the outcome is better now for people with BKVN than perhaps early on, when we didn't appreciate the importance of reducing immunosuppression and have the full armamentarium of antiviral agents. So we have two nice responses from the questioners. Dr. Randawa says, thanks very much for the broad overview and your unique insights, always stimulating listening to you, and I'm sure all the listeners agree with that. And Dr. Borkar says, thank you very much for your informative presentation. So I think at this point, if there are no further questions, I would point out that to get your statement of credit, you must complete the evaluation in its entirety using the following link, which is coming up. One of our participants, Dr. Krishnan, is typing as well, saying thank you very much for an excellent talk and discussion. So with that, great. I think we can end this seminar, and thank you again, and thanks to all the participants.
Okay, thanks. Bye-bye, everybody.
Bye.